Greetings, everybody. May I, on behalf of Te Huringa Mahara, welcome you to today's presentation of lived experiences of compulsory community treatment orders under the Mental Health Act of 1992. We're just going to do a little bit of whakawhanaungatanga of those of the staff from Te Huringa Mahara, and I'll kick us off. Kia ora anō, he uri au o te iwi o Ngāti Parau, ko Guy Baker toko ingo. He mahi au, he kai tohu whea ko Māori mō Te Huringa Mahara, no tūranga nui a kiwa in the Hoanga. I'm Guy Baker. I'm the Principal Advisor for Māori Whānau Lived Experience, and that is my role in today's presentation. And I'm from the East Coast. Yeah, I think there's a bit of sunshine coming down there today. But kia ora nō tātou, I'll pass you over to Alison.
Tēnā koutou katoa, ko Alison tuku ingoa kei Tamaki Makaurau e noho ana ahau. I'm a Principal Advisor for Mental Health and Addiction at Te Huringa Mahara, and was involved in the development of the report that we're presenting today. Katie.
Tēnā koutou e te whānau, ko Katie Sheriff toko ingoa. You won't be hearing from me too much in this webinar. I'll be facilitating the Q&A. I'm going to pass you over to Tanya Maloney.
Tēnā koutou katoa, ko Tanya Maloney, toko ingoa, ke no Waikato e noho ana ahau. And I am Director of Mental Health and Addiction with Te Huringa Mahara. Lovely to have you all join us today, and thank you for making the time to come and listen, but also to talk with us about the work that we're doing, and particularly about our work into compulsory community treatment orders. I'm going to start today just giving you a little brief overview about Te Huringa Mahara and our role, and particularly our monitoring role. Many of you know us already, so I will make this quite a quick introduction to who we are. We were established to contribute to better and more equitable outcomes for people in Aotearoa. So we have a role in monitoring and reporting on the mental health and addiction system, but also we have an important role in advocating for improvements to the system. We also have a role in assessing approaches to mental health and well-being. So we take an integrated approach to our monitoring. So we use our engagement, assessment, monitoring, reporting and advocacy, and bring those things together in our mahi and in our reports. So we're using all of those tools to influence and affect the change that we want to see. So, for example, in our reports, such as the ones we'll be talking about today, we do include calls to action and advocate for change to occur. The objectives of our monitoring are importantly to help people feel heard and validated. So we have a legislative function to advocate for the collective interests of people with lived experience, and that's a really critical part of our monitoring, is to bring forward those perspectives and voices. Our monitoring also is about holding the government and funders and the system to account, but also influencing decision makers and service and support providers at all levels of the system, and lastly to help shape the public conversation. And as you all know, that's a really important conversation that needs to occur in the context of the use of the Mental Health Act. We'll move to the next slide. He Athena is our framework for monitoring, and we developed this conceptual monitoring framework in collaboration with people with lived experience of distress and with critical input from people across the sector. So the He Athena framework was published in June 22. And it does bring forward the most important voices of tangata whaiora and whānau as leaders of their wellbeing and their recovery. So it does outline aspirations across 12 different domains. So we have a Te Ao Māori perspective and the aspirations of the system from a Māori perspective, and then also 6 aspirations from a shared perspective. These domains or aspirations align with the 6 domains of healthcare quality, so equitable, patient-centred, timely, safe, efficient and effective. And if we just move on to Te Huringa Tuarua 23, so we published our first service monitoring report back in March 22, before we had established, developed the He Ara Athena framework. So Te Huringa 23, this report that you can see on the screen, was our first report using the He Ara Athena framework. Te Huringa Tuarua includes a number of different reporting products, if you like. So a summary report that you can see on the screen, which covered the breadth of monitoring across all of the domains in He Ara Athena. But 3 focus reports took a closer look at a number of areas, and we wanted to shine that light on compulsory community treatment orders, which we'll talk about today, admission of young people to adult inpatient services, and we've had a previous webinar on that report, and also kaupapa Māori services. We published another report shortly after this Te Huringa Tuarua series, which was a report into the peer support workforce. And we'll also be talking about that report as part of the series of webinars. So today is an opportunity for us to talk with you about the lived experiences of community compulsory treatment, but also an opportunity to have a kōrero and hear from you about your thoughts in this really important area. So I'm going to now hand it over to Alison.
Thank you, Tanya. So as Tanya's already explained, the purpose of this report was to shine a light on the use of compulsory community treatment orders in practice by amplifying lived experiences of whānau and whānau voices. We're interested in understanding the impact of current practices on the people who are subject to these orders and the ensuing treatment, and we're interested in advocating for positive change now. The broader context for the report is the government's commitment to repeal and replacement of the current Mental Health Act following He Ara Oranga inquiry and recommendation. The Act's widely accepted as being outdated with respect to Te Tiriti o Waitangi, contemporary human rights based approaches to supported decision making and recovery and wellbeing approaches. And our focus in this report is on the clinical review, application, and the court hearing outcome as substitute decision-making processes under the current Act. And next slide, please, Katie. So this simple infographic shows how the clinical review and hearing events are part of the current Mental Health Act procedure that can result in tangata whaiora, or people seeking wellbeing, being under a CCTO. So initially, a person is compulsorily assessed and treated for a period, either in hospital or the community. Typically, they would be cared for in a hospital and discharged only after a clinician's review. A clinical review under the Act involves a clinician's assessment of mental disorder. For this legal definition, a person must have 1, an abnormal state of mind of such a degree that 2, they pose a serious danger or it diminishes their capacity to care for themselves. A clinical review requires consultation with whānau and family. And a clinician's opinion that a person is not fit to be released from compulsory status leads to an application to the family court for an order. Perhaps many of you joining will probably be familiar with this process, so bear with me. A court hearing is held either in hospital or community clinic rooms. provides independent oversight by a judge. Tangata whaiora are entitled to legal representation, and the responsible clinician prepares a report to support their application. A judge decides, a judge considers the patient view, the terms in the legislation, and consults with the responsible clinician in charge of treatment and at least one other health professional. A judge may also consult with any other people concerning a patient's condition, and the judge decides to grant or decline the order. So an approved CCTO requires the person to accept treatment for up to 6 months, with possible extensions and further applications. In practice, what this means, the treatment intervention that is compulsory under a CCTO is prescribed medication for psychiatric illnesses, administered as tablets or long-acting intramuscular injections, IMIs, and this sometimes involves a clinician entering the person's home to monitor oral medication or having to attend a clinic to administer IMIs. So the Mental Health Act in the early 1990s, in the context of closing the big psychiatric institutions, formalised CCTOs as a legal mechanism to extend hospital-based treatment under the Act to outpatients, again, term under the Act, for people that are living in the community. So we can move to the next slide, please, Katie. So for the year 1 July 20 to June 21, the Office of the Director of Mental Health and Addiction Services reported 6,817 people were under CCTOs. On a given day in that year, the average number of people under a CCTO was 4,608. So this equates to 90 people for every 100,000 in our total population. The use of CCTOs has increased over the last 5 years. In 2017, it was 88 out of every 100,000 people under CCTO, so the rates are increasing. Also, over the last 5 years, we reported the courts have consistently granted 88 to 99% of all applications made. And because made reference to a requirement in terms of consultation with family and whānau, we also have noted the national average for those consultations was 75% for the first application and dropped down to 59% for subsequent clinical reviews on compulsory orders. Next slide, please, Katie. So while our CCTO use is increasing, it's also inequitable and is increasing inequitably, especially in regard to Māori. The low rates of CCTO in some regions warrants further investigation. Social deprivation and ethnicity doesn't fully explain this variation between regions. And we think this means other factors specific to services in each area, such as workforce and options for support in the community, are also influencing CCTO use in practice. Next slide, Katie. So in the context of the report, you'll see we wanted to understand more about CCTO rates. We drew on some published research in this area. We found key studies reinforce that CCTOs have limited, if any, clinical effectiveness. And in these studies, effectiveness is understood in terms of reduced readmission rates to hospital. So it's measured by comparing people on CCTOs and populations who are not on CCTOs. Another area of relevant international studies focused on service user experiences of being under CCTOs and other stakeholder experiences of using CCTOs. And we found that in these interview-based studies, that also reinforced that these CCTOs are not experienced as beneficial for those subject to them. This is mainly because the enforced treatment or the potential for it undermines trust in treatment relationships and services, in turn increasing harm in longer term. We also found little published research from lived experience perspectives of CCTOs in Aotearoa, We think this is a significant limitation on available evidence, that can inform policy, law reform and guide rights-based practice. Next slide, Katie, thanks. So in line with our legislative function, Tanya described, we intentionally focused on seeking views of tangata whaiora, Māori and other people with lived experience. And to do this, we held focus groups, and we heard that people experienced these clinical review events, hearing processes as exclusionary. They felt silenced or overridden in these decision-making events, but importantly also outlined the ways that these practices could be improved now under the current Act to protect mana and uphold rights to the greatest extent possible. And over to you, Guy.
Oh, kia ora, Alison. These next slides reinforce what Alison and Tanya have been saying about what we were told from tangata whaiora. It's important to hear some experiences from our lived experience communities on the processes that affect them. They shared with us that there is a lack of communication and information sharing ahead of these planned processes. As a result, support providers, whānau and family had no opportunity to make the necessary arrangements to attend in the first place. They told us that people don't get time to prepare or to get an advocate or get familiar with the process, especially when distance travel was required. An example was given of getting to the hearing and being asked by the lawyer 5 minutes before commencement, what do you want from the hearing? The current Act requires consultation with family and whānau. However, some experiences where that whānau and family weren't consulted at all, with the result that they can end up feeling overlooked and powerless. Whānau and family spoke of being left out of these processes completely. Also shared with us was confusion around staff roles, the meaning of the terms clinicians used, and where and how to access support. We were told that clinician use of specialist terms, both when speaking and in clinical notes and reports, excludes and limits participation of tangata whaiora, as well as whānau and family. People emphasised that the information about these processes is really available in plain language, either in English or in other languages. As a result, it is difficult for tangata whaiora and whānau to advocate from their lived experience and whānau perspectives. We were especially concerned to hear people not getting access to clinical reports for the application and important evidence for the hearing. Tangata whaiora did not experience the process as an opportunity for their views to be heard at all. They told us that the places where court hearings are currently held, such as inpatient units, as inappropriate. They can have insufficient seating, and their waiting areas are not suitable for private conversations with lawyers and clinicians. These physical spaces were not welcoming and lacked manaaki, warmth, care, and hospitality. From a Te Ao Māori perspective on our next slide, clinical reviews and court hearings marginalise Te Ao Māori and lived experience perspectives. We heard that currently their feelings that processes under the Mental Health Act do little to uphold te tiriti or waitangi or include Te Ao Māori worldview. Tangata whaiora, as well as whānau and family, described how decision-making privileges psychiatric and medical experts and expertise with no consideration of cultural interventions. We also heard from tangata whaiora that when they do raise their concerns, feelings around shame and hopelessness that come from being under a CCTO are mistaken for symptoms, and that their expressions of disappointment are often mistaken as symptoms of their diagnosis, adding fuel to the clinician's perspective. From a lived experience perspective on our next slide, here we heard that discussion really occurs to plan the kinds of support they prefer. Instead, current processes prioritise medication and decisions made for, not by them, about their treatment. People found there was a lack of information on medications and side effects concerning, and especially when it's such a huge impact on your life. Medication is being forced on tangata whaiora without the other things that might support well-being. They spoke of a fundamentally disempowering structure that required them to keep with the plan rather than enable them to challenge it as they might do if they had more information. Both clinical reviews and hearings have insufficient time for discussion related to medication concerns. On our next slide, Whānau and people with lived experience shared how current practices do not protect mana or uphold rights, and described CCTOs used as a coercive weapon. That is, they are forced to take medication with the threat of being placed under the Act or secluded if they do not comply. These are realities. On our next slide, whenever tangata whaiora have supportive relationships with their clinicians, and acknowledgement is made that this occurs, there is no need for CCTOs. Those kinds of relationships, people said, involve discussion and collaboration, plain language information, no pushbacks, and more use of advanced directives and no cloak and dagger surprises. We heard that innovative approaches can be built on trust. For Whānau, the vision is to have more safe places for care and respite other than hospitals. An increase in support and advocacy more broadly is needed, such as peer support, as well as support in clinic waiting rooms following IMIs, after discharge from hospital, and leading up to and in the court hearings. Cultural peers workers and those in NGOs or community groups also need to be involved. For example, we heard from tangata whaiora that NGOs should have a place in the process that allows them to come in and advocate for the person in court hearings. On our next slide, please, Katie. Now, while we are aware that work is underway to reform the legislation, there is an opportunity that changes in practice can be made to improve people's experiences in these decision-making processes. Some of the changes that we heard from people include sharing clinical and other information in plain language, taking more time for decision-making involving whānau, family and other supporters in planning with tangata whaiora, and to support tikanga in court hearings. We recognise that clinical review and court hearing events are important mechanisms that exist to protect the rights of people subject to compulsory treatment. Yet, we find that courts grant a remarkably high percentage of applications in favour of responsible clinicians. Now, if courts continue to grant applications for extension at the same rate, which we heard is almost 90%, the legislative change to eliminate indefinite compulsory treatment orders will have minimal effect. Now, currently, the Mental Health Act prevents Aotearoa from fully complying with human rights because of its definition of mental disorder, combined with its requirement for a legal procedure that privileges health professional and legal professional roles. We acknowledge that clinicians and legal practitioners are also constrained in practice by this complex process, that perpetuates the use of CCTOs. On the next slide, we're calling for changes that can be implemented now. Though new law is being developed, we advocate that this must be based on supported decision-making, and that it embeds te tiriti o Waitangi and a te ao Māori worldview. In the interim, though, we would prefer to see reduced applications and outcomes granted for CCTOs, a reduction in the rate of their use through the changes that can be made. Inequities must be reduced and eliminated. We also want to see services and courts implementing cultural practice and other practices that ensure tangata whaiora as well as whānau and family perspectives are heard, and tangata whaiora making decisions about their care. Kia ora tātou. I'll hand over for concluding comments.
Thank you, Guy. So look, we acknowledge the work underway to replace the Mental Health Act, but also the work underway, the guidelines from Manatu Hauora that have been released over the last year or 18 months, and also work that is underway since July when we released this report. The foundational settings for the new mental health law have been released. The cabinet papers were released by Manatu Hauora, I think last month. And we note the work to implement a policy in line with agreed principles is underway. We also acknowledge the work by Te Pou and Manatu Hauora in the e-learning modules that will help to to influence and produce the change that we want to see. Look, in this report that we've talked about, we have intentionally prioritised the voices of lived experience, and you've heard some of those views from Guy. The intention was really to bring forward that human experience that's behind the numbers that that we all know about, and really to show the the impact that or to illustrate the impact that this community treatment orders have on people. We also acknowledge, though, that there are other really important voices to be heard and that will contribute to this conversation and to this process of change. The voices of and the expertise of health professionals, district inspectors, judges, lawyers are all critically important in this conversation. And will be important in helping understand some of the barriers and also the opportunities to progressing that change that we all want to see. We in Te Huringa Mahara are really committed to working with all stakeholders to support this shift in practice. And so we're really eager to hear from you about how we can help make this happen.